Hello everyone and welcome to another CB Clips. I'm coming to you today from the Chateau Frontenac in Quebec, and from this very beautiful place I would like to welcome all the new pediatric surgeons who just completed their training and all the new fellows who just started. Welcome to all of you to our pediatric surgical community. This week's CB Clips had to do with an esophageal atresia and a tracheo-esophageal fistula discovered after the repair of a Type C. Now, as most of you commented, this could either be a recurrence or a Misfistula. But the first clinical principle I would like to cover is that a recurrence is very unlikely to occur early if there has not been a major complication, such as a disruption of the anastomosis or a major leak. And as you can see from the study, the anastomosis actually looks quite good 6 days afterwards. So we have to assume that this, in fact, is a missed fistula. Which brings us to the next point. Why was the fistula missed? On our service, we perform a rigid bronchoscopy on all patients before proceeding to repair. So you think we should have found a proximal fistula. In fact, proximal fistulas can be very difficult to diagnose even at rigid bronchoscopy. This paper from the UK dealt specifically with this issue and looked at a series of patients with proximal fistulas. All were missed except for one. Why is that? Because they often do not look like an aperture or a hole in the trachea, like distal fistulas do. They sometimes can look like a fold or a depression or a subtle abnormality. And so it's very important to pursue this if you have any suspicion that there's a proximal fistula by injecting air in the esophageal pouch or putting some methylene blue or other maneuvers. In this case, we repaired this through an open approach. However, we did not want to go through immediately back to the chest or disrupt the esophagus in any way because of the fresh anastomosis. So we did try an endoscopic treatment, and you have the link to that in the tweet. When that failed, 2 weeks later, we actually performed the ligation of the fistula through the neck, and the patient did very well.